So the objectives of this talk is to define the general arrangement of the peritoneal cavity in the upper abdomen. When we talk about upper abdomen, we're talking about the abdomen excluding the pelvic cavity. Also to describe the different compartments in the peritoneal cavity, and then discuss different peritoneal spaces in the upper abdomen. To reach these objectives, we're going to talk about the general arrangements of the peritoneal cavity, and then we'll talk about the supramesocolic compartment with its divisions. It's divided into right and left with potential spaces in each of these divisions. And then the inframesocolic compartment with its right, left, and paracolic cathars. We'll talk a bit about the clinical significance as we move through different sections of the talk, and then we'll summarize and conclude the topic. So, general arrangement of the peritoneal cavity. The peritoneal cavity is a single continuous space between the parietal peritoneum lining the abdominal wall and the visceral peritoneum enveloping the abdominal organs. So the parietal and visceral peritoneum, they join together and they form a big sac, if we can imagine, and that's what we call the peritoneal cavity. This big sac contains two smaller sacs. The greater sac, which is the main region of the peritoneal cavity, and it is equivalent to the main abdominal cavity surrounding the majority of the abdominal and pelvic viscera. The other sac is the lesser sac. In anatomy they call it the omental bursa, and in surgery we call it the lesser sac. It's a small diverticulum lined with peritoneum, and it is situated behind the stomach and the lesser omentum. And it is also situated in front of the pancreas and the retroperitoneal structures behind the stomach. The greater and lesser sacs communicate via the epiploic foramen. It's a small foramen where fluid can pass from each of the two sacs into the other one, and we'll talk about that also. So, for clinical purposes, the peritoneal cavity can be divided into several spaces. Pathological processes often are contained within these spaces, but also can flow from one space into the other. The anatomy of these spaces may influence the diagnosis and the treatment for the surgeon dealing with fluid collections or hematomas or ascites, for example, collecting in these spaces. So it is useful to divide the upper abdominal cavity into two main compartments: the supramesocolic and the inframesocolic compartments. These two compartments are partially separated by the transverse colon and its mesentery going transversely across the upper abdomen. In addition to these spaces, as we've mentioned, there is the pelvic peritoneal spaces that we will not talk about in this lecture, but I guess it will be included in other lectures. So the supramesocolic compartment, this compartment lies above the transverse mesocolon between the diaphragm and the transverse colon. It is arbitrarily divided into right and left supramesocolic spaces. These right and left supramesocolic spaces are further divided into a number of subspaces, and these spaces are all in communication with each other. So we'll talk about the right supramesocolic space and then the left supramesocolic space. The right supramesocolic space is divided into three subspaces: the right subphrenic space, the right subhepatic space, and the lesser sac. On the left supramesocolic space is divided into the left subphrenic space and the left perihepatic space. So the right subphrenic space lies between the diaphragm and the anterior, superior, and right lateral surfaces of the right lobe of the liver. It is bounded on the left side by the falciform ligament and behind by the upper layer of the coronary ligament of the liver. It is relatively a common site for collections of fluid after right-sided abdominal inflammation. So in this picture we can see the right subphrenic space in that side. It is bounded by the diaphragm above, the surface of the right lobe of the liver, the anterior, superior, and lateral surface of the liver, and behind this by the coronary ligament of the right lobe of the liver. The right subhepatic space lies between the right lobe of the liver and the right kidney. It lies actually inferior to the right lobe of the liver. The boundaries of this space, it's bounded superiorly by the inferior layer of the coronary ligament, laterally by the right lateral abdominal wall, posteriorly by the anterior surface of the upper pole of the right kidney, and medially by the second part of the duodenum, the hepatic flexure, and the transverse mesocolon. Again, that space is inferior to the right lobe of the liver. This is the space here, the right subhepatic space. And it is bounded superiorly by the right coronary ligament of the liver, on the lateral side by the duodenum and the hepatic flexure and the transverse mesocolon, and on the right side by the right lateral abdominal wall. This is an axial view of the abdomen, and this is the space that we're talking about. Sometimes surgeons refer to this as Morrison's pouch, and it's in front of the right kidney, inferior to the liver, bounded on the medial side by the duodenum, and on the lateral side by the lateral abdominal wall. The right subhepatic space in the supine position is more dependent than the right paracolic catheter, which we're going to talk about. And post-operative infected fluid collections are common in this space, as we usually see if there is a post-operative collection post-cholecystectomy, for example. The third space in the right supramesocolic compartment is the lesser sac. The lesser sac is a cavity lined with peritoneum and connected to the larger general peritoneal cavity, which is the greater sac, through the epiploic foramen. We're going to talk about this foramen later also. It is considered part of the right supramesocolic space, as we've mentioned, because embryologically the liver grows into the right peritoneal space, and it stretches the dorsal mesentery to form the lesser sac behind the stomach. So it stretches the dorsal mesentery, and it forms the lesser omentum, and behind that lesser omentum and the stomach lies the lesser sac in the adult. The lesser sac varies in size according to the size of the viscera making up its walls. It has posterior and anterior walls and superior, inferior, right and left borders. This is another axial view of the abdomen, and this is a cross-section of the stomach. This small yellowish line is the lesser omentum. This is the edge of the lesser omentum. And behind the stomach here, this is the lesser sac. So it has anterior wall, posterior wall, and it has borders on each side, and on the superior side towards us, and on the inferior side towards the pelvis. The anterior wall, as we saw in the picture, is made up of the lesser omentum and the peritoneum over the posterior wall of the stomach and the first part of the duodenum, and the uppermost part of the greater omentum as well forms part of the anterior wall of the lesser sac. The posterior wall, as we've seen in the picture, is formed mainly by the peritoneum covering the posterior abdominal wall in this area. In the lower part, if you can imagine, the posterior wall is made up of the posterior sheet of the greater omentum. So the posterior wall of the lesser sac is formed from the pancreas, the left kidney, part of the abdominal aorta and the celiac artery, part of the diaphragm as well on the upper side, and then some vessels like the inferior phrenic, splenic, left gastric and hepatic arteries. Part of these vessels lie also within the posterior wall of the lesser sac. Less important actually to know is the borders of the lesser sac. but for completion we'll mention these. The superior border of the lesser sac is narrow. If you can imagine, it's on the superior side, so it's a narrow space between the right side of the esophagus and the fissure on the posterior side of the liver where the ligamentum venosum lies. The inferior border of the lesser sac runs along the line of fusion of the layers of the greater omentum. We know that the greater omentum runs from the greater curvature of the stomach downward and then upward again, and it's attached to the transverse colon, and the line where the two layers fuse forms the inferior border of the lesser sac. The right border of the lesser sac is formed by the reflection of the peritoneum from the pancreatic neck and head onto the inferior aspect of the first part of the duodenum. So at the neck of the pancreas, a peritoneal fold forms, and then it's reflected into the duodenum, and then it continues upward and lateral to forms the hepatoduodenal ligament, which is the right border of the lesser sac. This is the right border of the lesser sac. It starts here behind, reflecting the peritoneum over the pancreatic neck, and then the duodenum, and then it continues upward, forming the right border of the lesser sac where the hepatoduodenal ligament is, and behind that is the epiploic foramen. The left border of the sac, which is on that side, runs from the left end of the root of the transverse mesocolon, and it's mostly formed by the splenorenal and the gastrosplenic ligaments. So the epiploic foramen, we talked a bit about it. It's a short vertical slit, usually 3 centimeters in height. It is in the upper part of the right border of the lesser sac, which we've just seen, and it leads into the greater sac. It's an outlet of the lesser sac out into the greater sac, or vice versa. This is the foramen again in the picture where the arrow is. The anterior margin of the foramen is the hepatoduodenal ligament. You can see it there. Which is the thickened right edge of the lesser omentum, and it extends from the flexure between the first and second parts of the duodenum, and it goes up towards the porta hepatis. The anterior border, which is the hepatoduodenal ligament, contains 3 important structures. It contains the common bile duct on the anterior right side. It contains the portal vein on the posterior side, and the hepatic artery on the anterior left side. Again, we can see that here. This is the hepatoduodenal ligament, and the posterior side, this is the portal vein. Anterior to the right is the common bile duct. Anterior to the left is the hepatic artery. Okay, we'll move on to the left side of the supramesocolic compartment, and the first one is the left subphrenic space. This space lies between the diaphragm, the anterior and superior surfaces of the left lobe of the liver, the anterosuperior surface of the stomach, and the diaphragmatic surface of the spleen. This is the area of this space. This is the diaphragm. It lies underneath the diaphragm and in front of this anterolateral surface of the left lobe of the liver, and the anterosuperior surface of the stomach, and the spleen, which is not shown here, but you can imagine it's underneath that part of the diaphragm. So it is bounded to the right by the falciform ligament, and behind by the anterior layer of the left triangular ligament. This space is much enlarged after splenectomy, and we talk about this space much more when we do splenectomies, and there is a fluid collection after splenectomy. These fluid collections usually accumulate in the left subphrenic space. The left perihepatic space is also known as the left subhepatic space or gastrohepatic space. It lies inferior to the left lobe of the liver and extends into the fissure for the ligamentum venosum on the right, anterior to the main portal vein. We'll see that in the picture. On the left, the space is bounded by the lesser curvature of the stomach. This space is small in size, and it lies underneath the left lobe of the liver here. It's lateral to the falciform ligament, and lies underneath the left lobe of the diaphragm of the liver, and it's bounded on the lateral side or the left side by the lesser curvature of the stomach, and it lies in this small space here. That's why we call it the left subhepatic space. What about the inframesocolic compartment? Now we're talking about a compartment that lies below the transverse mesocolon and transverse colon as far as the true pelvis. It is divided into two unequal spaces by the root of the mesentery of the small intestine. It also contains the right and left paracolic gutters lateral to the ascending and descending colon. As a consequence of this, these spaces lie on each side of the small bowel mesentery, and because of the mobility of the transverse mesocolon and the small bowel, disease processes are rarely well contained within these spaces in the inframesocolic compartment, so the fluid travels between each of these spaces freely. So fluid within the infracolic space tends to descend into the pelvis or the paracolic gutters with movements of the bowel and the colon. The right infracolic space is a triangular space. It is smaller than the left infracolic space. It lies posterior and inferior to the transverse colon and mesocolon and to the right of the small intestinal mesentery. The space is narrowest inferiorly because the attachment of the root of the mesentery of the small bowel lies well to the right of the midline, we'll see in the picture, and the appendix often lies in the lower part of the right infracolic space. This is the right infracolic space. It's triangular in shape. This is the attachment of the small bowel mesentery, and this is the right colon mesentery attachment. So this is the attachment for the transverse mesocolon here. So this is the right infracolic space. And fluid tends to travel from here to the right paracolic gutter, which is in this area. And the inferior aspect of this triangle, or the inferior aspect of this triangle, points usually towards where the appendix is. The left infracolic space is larger than the right infracolic space, as we've just mentioned. It's in free communication with the pelvis to the right of the midline, and it lies inferior to the transverse colon and mesocolon and to the left of the mesentery of the small intestine. The sigmoid colon and its mesentery may partially restrict the flow of fluid or blood into the pelvis to the left of the midline. This is the left infracolic space. It's to the left of the small bowel mesentery and inferior to the transverse mesocolon, and medial to the left colon. And the fluid can travel easily and freely into the pelvis. This is the rectum, so it can travel into the pelvis mainly to the right pararectal space here. The paracolic gutters, the right and left paracolic gutters are peritoneal recesses on the posterior abdominal wall. They lie alongside the ascending and descending colon, right and left respectively, and lateral to the colon on each side. This is the right and left. This is the right paracolic gutter in this area, and this is the left paracolic gutter. The right paracolic gutter runs from the supralateral aspect of the hepatic flexure of the colon down the lateral aspect of the ascending colon and around the cecum, and it continues with the peritoneum as it descends into the pelvis over the pelvic rim. So fluid can travel easily from that side down into the pelvis. Superiorly, the right paracolic gutter is continuous with the peritoneum, which lines the right subhepatic space and the lesser sac. So any fluid like bile, pus, or blood released from the viscera anywhere along its length may run alongside the gutter and collect in sites quite remote from the organ of origin. So in the supine patient, infected fluid from the right iliac fossa, if the patient lies supine, may ascend into the gutter and enters into the lesser sac, or goes into the right subhepatic space or the right subphrenic space. In patient nursed in the sitting position, gravity will help the fluid from the stomach, duodenum, or gallbladder run down the gutter to collect in the right iliac fossa or the pelvis. And so in these situations, for example, patient with a perforated duodenal ulcer, or perforated gastric ulcer, the fluid can run through and along this gutter down into the pelvis or the right iliac fossa, and then clinically we might think that the patient has acute appendicitis or other pathology in the right iliac fossa or in the pelvis. And the right paracolic gutter is larger than the left. A partial barrier is provided by the phrenocholic ligament on the left side. And so this ligament might cause some restriction to the fluid traveling up or down on the left side of the abdomen. And that might explain why right subphrenic collections are more common in the left subphrenic, are more common than the right subphrenic collections. So to summarize the clinical significance, we've already mentioned a few points. Fluid collections frequently occur secondary to a wide range of pathological processes in the peritoneal cavity. Serous fluid is almost always distributed freely between the peritoneal spaces in the absence of any inflammation, peritoneal adhesions, or previous surgery. Ascites, for example, can be drained freely from any convenient dependent part of the peritoneal cavity because they can travel into each of these peritoneal spaces freely. On the other hand, pus, blood, or any inflammatory fluid are often more viscid and produce peritoneal adhesions, and collections of these fluids may become localized if the flow of fluid is restricted by partial compartmentalization of the peritoneum. Also, ongoing inflammation with these fluids may even form a truly walled-off cavity over time in any of these spaces. So any of these spaces of the peritoneum may develop a particular collection. The subphrenic, subhepatic, and pelvic spaces are the commonest to collect fluid because they're most well defined by fixed peritoneal folds and boundaries, and these are the most dependent spaces within the peritoneum in the supine position of the patient. And so understanding the anatomy of the potential spaces will help in the treatment, and the treatment is usually either radiologically guided drainage of these collections or surgical drainage if we decided to treat these fluids. So in summary, we've talked about peritoneal sacs, and we talked about the lesser and greater sacs. We defined the supramesocolic compartment, and we talked about its subdivisions into right and left. And the right supramesocolic compartment contains the right subphrenic space, right subhepatic space, and the lesser sac, while the left supramesocolic compartment contains the left subphrenic space and the left perihepatic space. The inframesocolic compartment, we also define the right and left inframesocolic compartments, and we talked about the clinical significance of these potential spaces. In conclusion, the peritoneal cavity is divided into specific compartments. Potential spaces exist within each of these compartments, and understanding surgical anatomy is important for the surgeon dealing with intraperitoneal fluid collections. Thank you.
Thank you very much, Dr.
You're welcome.
Maybe we will have the discussion at the end after the three speakers. Do you want to have anybody have a question now?